Chairman, ladies and gentlemen, we have here a nice group of the enthusiasts of intraventricular endoscopy. That's good to see. Selected group. So my task was to talk about long-term results of ETV. And I think it depends from the indication. The first thing which determines the outcome is the indication. So in our experience, only occlusive hydrocephalus is a good indication. All of our communicating hydrocephalus respond not very well, at least in the northern German population. But you know there are other talks which think it's not true, that also in communicating hydrocephalus it's a good indication. And the second thing is, of course, the right technique to perform a good ETV. And you see, what we want to have is a very good imaging to not mix up communicating with obstructive hydrocephalus, and you see here, you see nicely the bulging of the floor. So with a CIS sequence or Fiesta or Drive, depending from the machine you have, it's a high-resolution T2-weighted imaging. You see all the small membranes. Also in front of the brainstem, you see all these small membranes which might interfere with CSF pulsation. So that's very important that you have a good imaging. And then we place the entry point 2.5 centimeters lateral to the midline, usually on the right side, exactly in front of the coronary suture. That's at average, it's a very good. Then you see the floor. The floor looks very different. Usually you make the perforation in between infundibular recess and membrane bodies halfway in the middle, exactly in the middle. And then you are just behind the clivus, and that is the best point to go. Then we take a balloon to open it. You see here below is the Lilliquist membrane. This has to be opened as well, otherwise it's not working. So we want to see after each ETV the basilar artery to know that we are really communicating it through subarachnoid space. And you see the floor might look very different. Sometimes you have here an anomaly of the PCOM running in this area. Sometimes the floor is not translucent. And sometimes you have here a dominant PCOM as a embryonal origin of the posterior cerebral artery. And then, of course, you have to adapt your perforation. There's one example. There's a young girl with a tactile glioma. She has a huge hydrocephalus. And then you see this is the entry point. We can go down to the floor. We make a perforation. Then we take a Fogarty balloon. And then we open it. And then, of course, we want to see that the basilar is visible. So we take a 30-degree endoscope to make an inspection that we have really reached the space. And then when you go up, you see there is no damage to the of Monroe, showing that we have selected the right position of the entry point. And you see here, this is the flow void we want to see after surgery that shows that's a good communication. Sometimes we have an open aqueduct, but you see here membranes in front. So this is coined by Uwe Killer as an extraventricular intracisternal occlusive hydrocephalus. And what is very important in this case, when you open the floor, you have a lot of membranes. And then we go down with the endoscopic sheath of the little otoscope all the way down and open all these membranes. And frequently the membranes are very, very tough. Oh, it's not running. But all have to open. You see the abducens 3-4 membranes, we open it. And then you have a good the prerequisite to have a good outcome. So when you look at the literature, there are a lot of reports regarding the outcome. This is a case where I showed you that I made a mistake. I went too far anteriorly with my fenestration. You see, there was a very narrow space between the mammillary bodies and the clivus. And I open it. And then when we looked in, we saw that we are in the subdural space. And that's very important to check. You see, there is no basilar artery seen. This is the dura and the arachnoid sac. So when you see this, you know this is wrong, and you have to open it to come in the right space. So you see, this is now opening of the arachnoid to get in the subarachnoid space. So this is just an example to show it. What we have with the children, when we make an endoscopic third ventriculostomy, is frequent we remain with white ventricles. You see, this is a congenital hydrocephalus. There was no history of any infection or bleeding, so we made an ETV, although she was very young. And see, the ventricles remain white. It's a little bit smaller than before, but it's still white. But you see, after ETV, the percentiles went a little bit down, and then it runs parallel to the percentile. And she is now I think it's more than 15 years after the ETV, and she's still doing good. You see, this is 2017, so 13 years later. There are wider ventricles than after shunting, but still she's doing well. And when you look to the literature, there's a nice paper from Abhaya Kulkarni, and he showed that the size of the ventricles does not interfere with a good neurocognitive outcome. And that is a result also from the International Infant Hydrocephalus study with a 5 years health outcome. The neuropsychological performance was similar to the patients who were shunted, where the ventricles are significantly smaller. Then what is a nice indication was here a girl, she came with an occlusive hydrocephalus, was an incidental finding, so nothing was done. And then you see 7 years later, she developed a Chiari malformation. And then we just made a third ventriculostomy, and you see the serines resolving. So the secondary Chiari is also a good indication. This is the result of our series. Then 250 patients with obstructive hydrocephalus with a follow-up of 50 months, and you see the overall success rate was 67%. In adults, better than in children. And when you compare to the series from Joachim Oertel, he had better results. So it's very small, but I think it was almost 80% after 1 year, and then after 7 years, it was 78%. So the literature is very variable. Here was a Swedish study, and they found that the success rate was just 50% after 5 years of follow-up. So it's very variable. You can find any success rate depending on the publication you want to look. And many of these patients improved then after shunting. So maybe it's a combination of occlusive hydrocephalus with a resorption problem, what they have. And this is our series of communicating hydrocephalus, and you see the overall success rate is very poor, so we would not recommend ETV in these cases. And we had a study where we investigated all our children, and when you look to the outcome, you see it's age dependent. The children below 6 months of age have a much higher failure rate and required frequently a shunt. So when we have younger children, we do an ETV when we have an aqueductal stenosis or a tumor, but not when we have hemorrhage or any infection. This is different to the series of Ben Warford. He found the etiology of the ulcer was mostly infectious, and he was very successful with his endoscopic subventriculostomy. But when we have children below the age of 6 months and have hemorrhage infection, then it's a sign of a bad outcome. Usually you see when you look here down to the subarachnoid space, it's all occluded with membranes and bleeding residuals, so this is not a good idea in our opinion. And it's also stated in this systematic literature review and evidence-based guidelines that there's insufficient data to recommend endoscopic subventriculostomy and post-hemorrhagic hydrocephalus. And I would agree with this. So is CPC useful? Ben Worf series showed it's useful, but I think in the North American study, Ben, they could not confirm this, right? It's not clear still whether CPC is successful or not. And there's currently a study running, a randomized study to solve this problem. But here Ben Worf found that the addition of ETV and CPC provided similar results like with shunting in this population in Uganda. So, but this is still under investigation, where this combination of CPC is a North American population working or not, so far as I know. But Ben can tell that. Shunt failure is also a good indication. We had a series of some patients, 30 patients, and 60% we were successful, and all these patients had an occlusive hydrocephalus. And none of the communicating hydrocephalus, it was successful to try an ETV in the term of shunt failure. It makes no sense. Here. You see a lady, 40 years of shunt dependence, aqueductal stenosis, we just make an ETV, and immediately she starts to resorb the CSF and was doing fine. Of course, complications can happen. I made a meta-analysis many years ago. Mortality was 0.1%. Complication rates varying from the literature from 0 to 20%. In our series, we had 3 permanent problems: oculomotor palsy, diabetes insipidus, and confusion. And most of them was because the surgeon made a mistake, was too far close to the infundibular recess or too far laterally to cause this problem. And we had a lethal complication. It was a subarachnoid hemorrhage because the surgeon put the catheter behind the basilar, because there was the floor, the sinus. He was not in front, and then he ruptured one of the perforators, and then there was a rehemorrhage when the patient was on the ICU. And one patient died because of wound infection, meningitis, but this was an old guy with very poor general condition. But the first one was clearly a problem. You see, this is the basilar. He was too far posteriorly, and then we had this hemorrhage. This was one paper that we put together. And this is our series of almost 400 ETVs, and you see success rates depending. The best success rate we have in tactile gliomas, then aqueductal stenosis, and then it goes more down when you have an indication which is not ideal. Mortality was 0.5 and permanent motility 0.8%. So ETV is a gold standard in obstructive hydrocephalus. It's very important to open all these arachnoid membranes, and hydrocephalus is good, and ETV is good in obstructive hydrocephalus, but it's not a good indication and community in hydrocephalus in our experience. Thank you for your attention.
Are there any questions?
All clear. So the indication is the most important aspect. And when you have good indications, then you have a good success rate. And technically, it should be, of course, performed in the regular manner to avoid complications. Yeah.
Hi, my name is Elijah from Zambia. I just want to find out, so what are some of the techniques you use to perforate the membranes?
I usually do it blunt with a deck forceps. Deck forceps has the teeth outside, so when you go, you puncture bluntly and then you open it, and so the floor is not slipping. You can also take a forceps. Before we had this forceps, we just take a biopsy forceps, but then the floor slips over the branches of the forceps. And when we have the initial perforation, we take a 3 French Fogarty balloon. It's very rare. Sometimes the floor is so tough that it's not working. And then I take scissors to open it. Or what I shown was bipolar coagulation. But this is the exception. Usually just blunt.
Okay. Have you ever considered water jet technique?
No, water jet is, in my opinion, risky because the jet is not stopping. When it goes through, and you can hit a hole in the basilar, and this can be depending what pressure you have in the water jet dissection. Also, we don't use laser. Although there are some lasers which have only the energy in the contact, they have no action in the depths, but I would not recommend. Just blunt is easy and is in most cases successful.
Okay, thank you.
Thank you for your presentation. Hanan from Saudi Arabia. So I would, have you ever considered redoing the ATVs in a good surgical candidate patient if they failed once?
Yes.
Like with aqueductal stenosis?
Yes, we do. When we have, to evaluate the success is the clinical symptoms. Some people say it's a success when you don't put a shunt. But if the patient is doing not good, you just put not a shunt, it's not a success. So clinical should be the improvement. The second thing is the ventricles usually come down. When we see that the patient is not good, we make a new MRI with this flow-sensitive sequences. And when we see there is no flow void, then we go in and make a new ETV. Only if we have seen during the first surgery that the subarachnoid space is not scarred by membranes. When we have seen during the first surgery that all the membranes are in the floor and we try to open it, but it did not look good, especially after hemorrhage or infection, then we would not do another ETV. Then we would stop. But if it looks very good, and it's just the reason for the failure is that the floor is closed, then we would do it. And I have seen many patients from other institutions, after ETV, they open just the floor, but not the membranes down. They open the lidiquist membrane, but when another membrane was further down, they did not open. And this might be the reason, because the CSF has to pulsate in front of the brainstem. You see it in the CNE MR images, what in a normal brain, how this pulsation is. And if this is not possible because of membranes, then I think it's a higher risk that the ETV will be closed. by scar formation later on.
Okay, so what if it's patent in MRI and the patient is still symptomatic? Would you reconsider exploratory ETV or going further for shunt?
No, usually we go with an endoscope to look, to confirm.
Okay,
And if you see it's open, then we put a shunt.
thank you.
Great, thank you. Oh, wait, do you have, just, because we don't have, you can, one more question? Sure.
Just wanted to just wanted to find out what would advice would be as part of the learning curve in doing an ETV. Would you recommend putting up an external ventricular drain on the patient and maybe removing it when you're sure that your ETV is working, or maybe just putting a burr hole for external ventricular drain and leaving it in case the ETV does not work and the patient deteriorates later?
Okay, thank you. So as you guys know, there's a couple of speakers who haven't shown up, so we're changing the order on the fly a little bit. So actually the next speaker is our ugliest speaker, and that'll be me. So keep it. First time I ever had to introduce myself. Can we do slides that cost? Okay, great. So so I'm J.B. Cameron from the University of Calgary, and so I'm going to be presenting this on behalf of the Hydrocephalus Clinical Research Network, and I apologize for those people that were in the IFNE. I presented a very similar one a couple weeks ago in Singapore, but let's see. Okay, no major disclosures. This is how we're funded. I do want to just, working with one of my residents who just graduated, he's a health economist, and he's been a major driver in this study. All right, so we all know for baby or infant hydrocephalus, there's two treatments, shunt and ETV-CPC. Shunt is the time-tested, tried and true. 30% failure rate, though, at 3 years has always bothered us, and that's better than it used to be. It used to be 60%. 5 to 10% infection rate, frequent trips to the ER. That's why we've always looked for something else, plus the costs of the shunts, especially in low to middle income countries. ETV-CPC, a variable failure rate, anywhere from 20 to 60%, depending on etiology and depending actually where you live in the world. And but there's no shunt infection and maybe more follow-up costs. Quality of life, I'll get to in a minute. So this is really two studies that are kind of lumped together. So the first study is we just want to see costs, like imaging, visits, and admissions. Those are the major drivers of costs. And so this is a 14-center study. We used our registry, also known as the Core Data Project, and we used the inclusion criteria of the trial that's going right now. And it's basically simple. It's just children under the age of 2, all etiologies of hydrocephalus except for preemie IVH. And so we took the last 200 ETV-CPCs and the last 200 shunts that each had 3 years of follow-up and then followed them for those 3 years, and then examine their number of CTs, MRIs, clinic visits, emerge visits. Okay, so this is our data, and it just kind of shows that it's pretty a wealth. The HCRN has a wealth of data in it. So 1,000 CTs, 2,000 MRIs, 3,000 clinic visits, and just these 400 patients. So first of all, you always got to look to see if your cohorts are balanced. And the first thing you're going to notice that the race is not balanced, that if you're white, you're more likely to get an ETV-CPC. However, it's contaminated a little bit because of the not available. Some of the centers, believe it or not, you're not allowed to cover, you're not allowed to look at race. It's a little bit old-fashioned, but they're coming around. The other thing is the follow-up duration. The ETV-CPCs were followed up longer because when you want to go back in time and find the last 200, it's really easy to find the last 200 shunts. It takes a little, you have to go back a little further to get the last 200. But we adjusted for that by stopping the follow-up at 3 years for both. Okay, so when we compare them univariately, we see that that ETV-CPC kids get less CTs, more MRIs, and more clinic visits, but are not going to the ER any differently or hospitalized any longer than shunts. But I just told you that they weren't balanced. We were comparing a little bit of apples to oranges, but because it's non-randomized, but when we adjust for age, etiology, and comorbidities, of which the comorbidities were nicely balanced between the two, we get the same results. So in conclusion of the first study, ETV-CPC, again, less CTs, one more on average, one more MRI than their shunt colleagues, and 1.5 more clinic visits each. Again, we expected to see a difference in ER visits. We did not. And it should be interesting that the ETV-CPC kids spent more time in a hospital in the first 6 months compared to shunts, but then the shunt kids caught up. So it's like long-term gain, short-term gain kind of issue. Okay, so now that data can be, the reason why we did that first study is to get the data to put it into an economic model. So first of all, you know, this is a hard sell for clinicians. Everyone's like, oh, we went into medicine so we didn't have to go do economics. But too bad, everything's economics. So it's used in everyday's life between menial things and massive things. So decisions, how much grocery stores do economic analyses, how many brands of peanut butter should I put on the shelves to make it cost effective? Countries like Ukraine and Russia are constantly doing economic analysis, where to move troops, when to send supplies, is it cost effectiveness to send more troops? So no matter where you are in life, you're using cost effectiveness studies. So, or we have a randomized control. The NIH is spending $10 million to answer this question. Why are you doing this? So the answer is that trial won't be ready for 5 years because we're following all the kids till they're age 2. What if it's a tie? Okay, so tie always goes to the cheapest. So economic analysis will tell us about that. What if it's mixed result? What if ETV-CPC kids are doing better cognitively, but worse with clinical, with complications and other things? It can help balance it. And what about if there's subpopulations? Like maybe there's a population where shunting is better, and then another one where ETV-CPC. A trial won't tell you that. It'll just tell you the gross thing. So that's another reason to do it. And then the other thing is you can do sophisticated things like what failure rate of ETV-CPC is tolerable in a center to make it cost effective, just kind of like in the carotid endarterectomy studies. So just an example of how this can be impactful. So aortic valve. So the surgical aortic valve is the classic and the standard treatment. And then the transaortic valve insertion through the groin, minimally invasive, came in. And they did a study, and it was a non-inferiority study. And it's shown to be non-inferior. So you would think naturally people would be like, oh, this is a cool new minimally invasive, let's do that. They didn't. People don't like change. So it wasn't until this study was done, a cost effectiveness study, which showed that the minimally invasive did cost more, but the quality of life improved significantly with the minimally invasive and overbalanced it and showed that it was actually cost effective. And that's, you'll see that 28,000 number. As long as that's under 50,000, it's very cost effective. So once this study was done, all 10 provinces in Canada then funded this procedure and is actually recommending it. Okay, so just a little thing, just so you know, for economic analysis, this is probably why people don't do it. They get scared of it, but I would say don't be scared of it. We talked about something like health utilities. So health utilities is between 0, you're dead, 1, you're perfect, and we all live somewhere in between. So the most interesting one is a stroke, a disabling stroke. You're usually at a 0.4. And then when you hear quality adjusted life years, so if I have a stroke, and I'm living with a stroke for 2 years, that's 0.4 plus 0.4, but I get a little bit better that third year to 0.7, then I'm 1.5. So my twin brother, who didn't have a stroke, is a 3, and I'm a 1.5. So that's basically how they work. Okay, and then we just compare costs and those qualities. All right, so first thing, we want to build the model. So there's 2 big steps you have to do is build the model and then get the data for the model. So, and it's usually step 2 that people don't have. So step 1 is build the model. So every permutation and combination is put into the model. So for instance, I can't have a pointer here, but if you have an ETV-CPC and it's working, you're in remission, so you're well. But then if it fails, you can go into a shunt, and then that shunt can get infected, or the shunt can do well and go into remission, or it can do a repeat ETV. You have to plan out all possible scenarios, so that takes some time. Next, you have to feed the beast. So each one of those, let me just go back. Each one of these nodes, you need data. And you need good data. And so we're lucky with the registry. We have data on over 38,000 shunts and over 22,000 patients. So we have specific data, like some people say, oh, what's the intraoperative abandonment rate in North America? Well, we have that for ETV-CPC, it's 2.8%. And there's published data too we can compare to. So that's, though each node has that. What's the shunt infection rate, but not just shunt infection rate between 5 weeks from surgery and 26 weeks. So we can even specify those very specific risks, and that's 3%. And then we're able to get some cost data from the Canadian centers. The governments will give you the costs. In America, the corporations, the health corporations will not. So we have the advantage of having Canadian centers. And then we need those health utilities, that's 0 to 1. So if you have a shunt or an ETV and you're block free and you're just living your life, you're actually 0.8. We have decent numbers for that. So that's an example. However, that quality of life data, we don't have very well. So any young people in the audience, you want to study impact, we need more quality of life data. This is just a study we did. In all the literature, there's really only 10 good studies that show quality of life, and some of them are flawed. That's just what that's supposed to show. So, however, we have a little bit of quality of life. That Mandeep Tamber and Rob Naftel published this paper, and it's looking at ETV-CPC versus shunt and parental attitudes. And more than half the participants would choose an option that had higher risk, ETV-CPC, to save an implanted device. So this is qualitative, not quantitative, and we need to quantify that. So in our model, though, because we don't have any data suggesting life with an ETV and life with a shunt is any different, we purposely set it at the same. Okay, so that's really important. And they probably aren't the same, by the way. But okay, and then you run the model 10,000 times, and then this is what you want to see. You actually want to be, you want to be in this quadrant. So here is costs, high cost, low cost, high quality of life, low quality. So ideally you want to be here with low costs and high quality of life. But we're here with higher costs and quality of life, which is second best. And you can see that ETV-CPC, a policy of doing ETV-CPC as the original treatment for infant hydrocephalus is a little, costs a little bit more, but the overall quality of life is better by 3%. And you think, oh, 3%, that's nothing. 3% is not nothing. That's actually a decently high number. And it's under 50,000 again, as you can see there. So a policy of original ETV-CPC for all new infant hydrocephalus cases is cost effective, even with high failure rates. So how high of a failure rate? So with this modeling, this is what you can do. You can leave the shunt, leave everything the same in the model, and artificially change and see how the model predicts. And in this case, you can have a failure rate of up to like 59%, and ETV-CPC is still cost effective. So things like myelomeningocele, we know that like Boston and Uganda, I think their rates are like 82% with myelomeningoceles. I think our network's about 65, 70. There they are on the curve. And so with myelomeningoceles, it's not even close. I mean, this type of data would almost tell you you shouldn't shunt a myelomeningocele. You should do an ETV-CPC. That's how strong that economic analysis looks. Okay, and then what we can do here, that's those same blue and the green line, but the red line there is what ETV-CPC would look like if it was 2% better. If the fact you don't have hardware in, you are happier, you're less worried about going to emerge or something like that. I'm not sure that's the case. We have no data to prove that, just sort of what families can sometimes tell us. And you can see if it's the red line, then ETV-CPC will be cost effectiveness even if it fails 80% of the time. Okay. However, we need better health utilities. So given the current data, policy of ETV-CPC as first treatment is actually a cost effectiveness one. Please remember this doesn't count for preemie IVH, which is the #1 cause of hydrocephalus in North America. And we will take this model and then we'll update it with the trial. We'll have even better data, and then we'll redo the model in 5 years' time. But also it's just a call again for better health utilities and quality of life data, and we'll get to know more and more precision on how these kids are doing. Thank you. Henry.
shunt against CPC ETV? What is better?
So we have studies like that. The HCRN's published that. Uganda's published that. Boston's published that. And like I don't have the curves there, but Abco Carney would show you the curves there that at the beginning shunt looks better, and then over time ETV CPC takes over because it sort of hits, it stabilizes, and shunts steadily decay over time. So the answer is complex. Early on, shunts in the first 6 months. After 2 years, definitely ETV CPC. But that's provided you're already a winner because your ETV CPC is working for 2 years. So if you're working at 2 years, it's likely to work maybe forever or for many decades.
So outside the HRC and data, the Benvarp's data, when you are comparing, you have earlier compared for HRC and the difference between ETV and CPC, which wasn't significant. ETV and ETV plus CPC. So for this study, why have you not chosen the third arm of ETV alone?
Yeah, that's a good question. So because ETV, again, I'm just speaking from a North American standpoint of view, so it was completely abandoned for infants, certainly under 1. I know the Europeans and other places never abandoned it totally, but in North America, like, you really weren't offered an ETV under the age of 1 ever, and you can argue under age of 2. And it wasn't until 2005 when Dr. Worf published, and then people were like, whoa, wait a minute, we might have a solution here. So there was no data in North America. We'd have to reach outside and use the European or the Asian or the African data. Okay. Great, thank you very much. So next, I think Mohammed is not here either. Let's see. So our next talk, if I could get, yes, Dr. Diop, please, with his talk on secondary third ventriculostomy.
Thanks for this opportunity, the WFNS Neuro-endoscopy Committee and the chairperson. Unlike what we have heard from Henry, I am going to talk about experience with failed ETVs and failed shunts. And probably we have a little different conclusions, though it's a single center or 2 center, but same unit kind of a study. So basically, endoscopic third ventriculostomy is well established, as most of you already know. And as Henry said, that in communicating hydrocephalus, it has probably 50% or less success rate, which is acceptable to some. What is emerging actually in the last 15 years or so, that it is very useful in shunt malfunction, especially in some patients, and can achieve shunt freedom in a large number of cases. This is one of the first patients I treated about 12 years ago. This was a 3-month-old infant who came to us with a shunt failure. And we decided, after making sure that the CSF was normal, the patient has obviously had a post-hemorrhagic, post-infective kind of a hydrocephalus for which this was put. But the scan showed normal fourth ventricle, and therefore we attempted on parent's request. You can see that there are adhesions. You can see that there are some adhesions at foramen of Monroe. There is a opaque kind of a third ventricular floor, though you can manage to see. And these are the kind of tubercles, though this was not non-tubercular. And here we managed to find a space, and we'll go ahead with making a hole. And once you have done, we usually do not use the forceps unless it is with Fogarty, the simple Fogarty balloon, which is used for vascular work. And you can see that there are some flimsy kind of adhesions, but you can see the prepontine space reasonably well. And therefore, we came out in this patient, keeping in mind that we may have to probably consider further surgery. Why is this happening? Okay. So these kind of procedures, we started calling them secondary ETV, and it can be defined as either a redo endoscopic third ventriculostomy done after primary ETV, stroma closure, or the ones where we do it after shunt malfunction. And this was first described in 1993 by Oka. And the Paris group actually first talked about a series of 30 patients where they found a 76% success in previously shunted patients. And of course, a lot of our decisions after this formula, or the ETV score as it is called, came after the Canadian trial, of which our chairperson was also a member, I think. And we knew that some of the etiology and the history of previous shunt was probably not favorable. But what was seen also by some other groups, like this is an Italian group, which showed that age younger than 2 years probably is a significant negative predictor, though their overall shunt malfunction ETV success percentage was 65 to 75%. And this is a 3-center study from United States published about 5 years ago, which has again showed that ETV success was close to 70%. And they also showed that age was predictive of ETV failure less than 2 years. So this is a patient I treated just about 3 months ago, a 8 days old child, alert, active, playful, good cry, full eye movements. And this was the MRI. And the parents came to me that, why don't you do a third ventriculostomy? And I explained to them that probably it may not be a good idea. I think there are many unfavorable features, and your success score is only about 50% because of the age. And we proceeded to do a shunt. As the luck would have it, the child developed shunt malfunction in about 3 weeks, came back with swelling at the scalp, and we found that the CSF was mildly infected, so removed the shunt. After 2 weeks of antibiotics, the parents again requested, why don't you try the third ventriculostomy and not go for shunt? So we proceeded to do a third ventriculostomy. The basilar artery looked good. There was no prepontine, and over the last 3 months, the child has been quite well. So I think there are some papers which have also shown that regardless of etiology, you can have a good result. And most of these are with secondary third ventriculostomy rather than primary. So this is one of our patients who presented with tubercular meningitis, had earlier shunt performed, and 4 or 5 years later he came back with a shunt failure. And at that stage we removed the ventricular shunt and went ahead, and you can see a reasonable floor, and this patient has been well now for more than 8 or 9 years without any further surgery. And you can see typical kind of web which you see near the third ventricle. This is a spina bifida child, again shunted at the age of about 3 weeks, and came back at the age of 4 years with shunt failure. You can see the active hydrocephalus here. And in this case, we actually found one of the common anomalies which you see is atresia of foramen of Monro, but we had a large spontaneous septostomy here through which we could go on the opposite side and could perform the third ventriculostomy. And it's more than about 3 years now. The child is doing quite well without any further surgery. So the general feeling is that the absorptive capacity increases over a period of time, and in Robert Jones' study and Grotenhuis' study, though the primary success rate was close to only about 25%, the secondary success rate was about 78%, which has encouraged us to do this kind of surgeries further. And I think one of the most important papers I find is from Chinali's group, which have shown that whatever the age and the etiology, probably the role of radiological anatomy is most important. If you have a small fourth ventricle, probably you should give a chance. And we then studied our 42 cases about 5 years ago, when we did 4 redo ETVs and about 38 shunt failure cases, and we had 70% success rate in shunt malfunction and 75% success rate in at the end of 1 year. This is one peculiar patient we treated, a 20-year-old boy who came after 16 shunts had failed, and in fact 3 shunts were protruding because he had developed silicone allergy. And at this stage, they said that we would like you to try whatever way it is possible. The floor was very badly scarred, and with the help of ultrasound and navigation, we decided to go ahead. You can see that there is no semblance of membrane there, but then once we confirmed, the ventricular floor made sure that this was the small quadrigeminal cyst which we first perforated, and then we went ahead, and with navigation guidance, we went for making an opening here, and we have dilated the opening. You can see it very, very thick scarred opening, and you can see that there is a second membrane, and as Henry showed beautifully, you need to open the second membrane as well. And once that was opened, this boy did very well for 2 years, and at the end of 2 years, actually, he had come with symptoms, and we repeated the ETV the second time, and that has gone on well. This is the way we validate our stoma. These patients get a sinusostonography done afterwards. So in some patients, we have additionally performed septostomy and aqueductoplasty, like this patient with tubercular hydrocephalus. When he came with shunt failure, he had mainly unilateral, and here we performed a foraminoplasty and then did a third ventriculostomy, and this has worked well. We do not remove the shunt immediately. If the patient wants, they would come back at 3 months interval to get the shunt out if they are doing otherwise well. There's another 9-month-old child who presented with triventricular hydrocephalus, and we went ahead and did a third ventriculostomy in this patient. As you would see, that though it looks reasonably well till we get there, and once we perform the perforation, you will find that there is a very scarred kind of a prepontine space. And in such patients, we try to look at the aqueduct. This patient had a membranous aqueduct obstruction, and in such patients, we would add aqueduct briefly. We would not use any energy source or stylate to use this. And this patient has done well now. We have a fourth ventricular, sometimes we have done also aqueductoplasty in those patients and cannulated the fourth ventricle for future shunt requirement. In multiloculated hydrocephalus, again, the ultrasonic guidance comes in use, and we have done even ETV with ultrasonic guidance in some of these patients. And whenever we are not sure if we are likely to be successful, we try to make sure before we discharge the child, we keep a reservoir and do a CT cystono study at 0, 6, and 24 hours to see if the dye has spread in the subarachnoid space and has cleared up. Now we have an experience of about 64 patients, 55 children and 9 adults, where again our success rate for children is about 66%, ranging from 3 months to 2 years. These are all 2-year follow-ups, and 66% in adults and 70% in children. Thank you for patient listening. So I think we still try to use this as a possible mode of treatment if either a parent's choice, or sometimes we feel that we are more likely to get successful from the available data and our previous experience. Thank you.
Oh, there's a question back there. Oh, he's here. Okay, Stefan. Yes.
Thanks for your talk, Chandra. I just have a question which relates a bit to what Henry commented before. So, do you ever use a lumbar drainage immediately post-op to, let's say, start the flow and to gain some more time until resorption may increase, like to elevate the drip chamber or things like this? Do you have any experience with that?
We have not used drip chamber, but for post-hemorrhagic, post-infective, and all infant ETVs, we do 3 lumbar punctures alternate days following surgery. First day they get a scan, and if there is no significant subdural or hemorrhage, they will get a lumbar puncture on that day, 3rd day, 5th day, and they are discharged on 6th day.
Okay, thank you.
Henry?
Why is the ETV communicating hydrocephalus not working in Germany?
Henry, I seriously do not know the answer to many questions, to tell you frankly, but certainly not this question. It is just like why ETV CPC works in Africa and in Boston and not so well many other places. I think your question is right in the sense that for a spina bifida child, I would not advise an upfront ETV. So the practice still is to do shunt to begin with, but if the child came back after the age of 3.5 to 4 months, I would then probably suggest them that we can try this out if you wish.
I also have a quick question. What is your intraoperative abandonment rate? Like, you presented those that you were able to complete it, but how many did you not go in there and say?
It's a very good question. I do not have the exact percentage, but it is about 10%.
Thank you. And then Dr. Wharf?
Specifically in regard to the spina bifida population, we're not talking about ETV alone. ETV alone has a very high failure rate in infants. And in terms, the same in terms of communicating hydrocephalus. What we're talking about is ETV with plexus cauterization, just not to get that confused. And I was struck by one piece of your video where you looked in and you saw that low membrane down below there. That almost looked less like prepontine scar to me and a secondary membrane. Sometimes there's a secondary membrane. And another option might have been to have just fenestrated below that into a very nice open space instead of risking the aqueductoplasty. You can do that much easier with a flexible endoscope, though.
Okay. All right. Okay, last question, and then.
Yeah.
Are you ready?
Yeah, actually, I have nothing more to add. Thank you, Professor Waf. What he said, this is what I wanted to ask because I saw the video as well. And actually, using the flexible scope, we can reach the prepontine system. And this is what we have found that communicating hydrocephalus children in Africa, ETV works very well because this is what we do with combined CPC. So I don't know how we can do with a rigid scope, or maybe we need to investigate why, if you do an ETV without reaching a prepontine system, ETV doesn't work in children. But in our cohort, even a child of 1 day old, ETV works.
I mean, if I can ask a question, I do not know how do you counsel, in spite of some successes, I still find it very difficult to counsel to treat an infant or, when you treat a post-hemorrhagic, post-infective hydrocephalus. It still is difficult.
Yeah. Okay, we'll get to our next speaker, Dr. Sharif. Yeah. Perfect timing.
Thank you. Wonderful to see all the friends again, and it's my honor to be here. Let's see if we have got it here.
Can we get the slide?
Oops. Well, I didn't know where this session is going to be and what's going to be about, so unfortunately I was in the spine session giving a talk, just coming from there directly. But it's good that I was smack on time, so I'm grateful. Thank you. But this is basically about how we have improved our results with ETV in causing less complications to our patients. So we all know this, what we do, how we go about it, look at what needs to be looked at on the MR and what needs to be looked at on your radiology, so you need to know beforehand what are the problems that you need to look at. So especially patients with large interthalamic adhesions and small prepontine cistern are not ideal. Yes, there are ways of going around it, but there are problems associated with, so you need to be careful. You need to look at which foramen of Monroe, etc., and you need to make sure that access, etc., is good, and you need to look at what are the factors that makes ETV successful, and then obviously you choose those levels. There are various types of techniques that are available, and people use it. I used to do all these freehand, and then I changed when I saw a couple of my senior residents doing surgeries and causing big contusions onto fornix. It did not result in problems, but at the same time, I was very, very worried that what would be the outcome once I saw those videos. So we went back, we looked at our patients, and we found some of them did have some memory issues. So I think it's something that we need to look at. And we thought that we are doing pretty good with our ETVs, so we changed and we started doing image-guided ETVs. So all ETVs are done routinely now image-guided. Obviously, you look at the trajectory. When you're doing image guidance, you need to, just 1 second, if I get the pointer. Yeah, so you need to make sure you get your foramen Monro and where exactly you're going to make your opening, and then you just take it up, and then once you get there, then you know where exactly how, what your entry point and where exactly are you going to go. Obviously, then you need to look at your burr hole needs to be on the proper side, and you need to make sure that you want to be entering on the right side, whichever side you're coming from. And your foramen Monro on that side tells you exactly where you are, depending on your thalamostriate and septal vein as well. Neuronavigation obviously helps a lot in this, because then you can plan beforehand, and you need to ensure that you're not causing significant problem. Every patient is different, obviously peds or adult or whoever it is. I think if you're wary of that, then it's okay. We used to make all these openings a centimeter in front of the coronal suture, and thinking that is probably the best trajectory. But over time, we realized that it was not the case. Majority of our cases were done with pre-coronal burr holes. So surgical technique, we all know this, nothing exciting to tell you about this. So step-by-step opening is also shown here, and obviously you need to be careful about basilar, the oculomotor nerve. I think that's important for us. Again, when you've got some adhesions underneath, as just shown here, obviously you need to make sure the prepontine cistern is completely open. So we see a 55-year-old basilar aneurysm with acute obstructive hydrocephalus. So this is actually not a patient of mine, it belongs to Professor Orotel, and he presented like that. If I can play, no, 1 second. Okay, so basically what it showed was that once we put in our monopolar in there, and all we had was big blush of blood, and this is wash, wash, wash. Eventually, this patient, over time, it was then not possible to do an ETV through that, and then this patient over time slowly got better, still has some memory problems, still has some problems associated with thalamic injury at that time, because when that blood happens, there's washing, washing, washing. So it's important to know beforehand if somebody has had a problem. So you need to look at the MRI very closely in these patients as well. So that's what we learned from that. Hemorrhage could be a significant problem in these patients from vertebral. Thank God I haven't seen any in one of my patients, but I've seen nearly in every conference somebody is showing these pictures. So we need to try to avoid them. Delayed arousal from general anesthesia, I've seen that. And it's maybe because of your irrigation, your drainage may not be as good as your irrigation, so you're irrigating, but at the same time you haven't checked where the water is coming out. And routine induction of ICP monitoring could be used in some of these cases if you're in trouble. But at the same time, keep checking whatever is coming in is going out as well. Most common intraoperative complication can occur during various steps, when the scope enters the lateral ventricle, during the passage of scope into the third, or obviously causing problem to the serous artery. If it's rupture of the basilar artery, you just wash, 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 and it takes about 15 to 20 minutes of non-stop wash that you may hopefully end up with some kind of hemostasis at that stage. Neural, obviously, fornix is important for us, and we have looked at it very carefully. We've published on that as well. And then, obviously, thalamus and midbrain could be injured at the same time. We have hormonal morbidity associated with it. There's systemic morbidity associated with it. So all these could be there. So it is a simple procedure, but at the same time could have serious morbidity. So this is just over a long period what was done. So look at what the success could be, looking at your MRI, and then depending on decide that this will be successful or not. Not going to go into details of what and how we did them. Complications showing 25 clinically relevant complications, 8%, 2 deaths, 1 ETV abandoned, and the other complications and transient morbidity is shown here. So all these could be a problem, and we need to be wary about this when you're doing this. Unfortunately, the videos are not working here. And this is the overall in last couple of years, morbidity and mortality is completely reduced because of knowing exactly how problems could be addressed. So we need to be wary on what we're doing. And although these are simple procedures, but can cause serious consequences. Thank you.
Any questions? Dr. Schroeder.
Thank you for this presentation. I think it's very important that we talk about complications, because complication rate of ETV is underreported clearly, because I'm expert witness, so I get many cases from Germany, and many patients died from ETV. They don't dare to report. We reported our case because I think it's important, but many people don't do. And if you make a mistake, and that can easily happen when you don't do it technically correct, ETV can be a disaster. And that's why we should be very frankly talk about it, because the rate is much higher than reported in the literature. I know that.
Agree, Henry?
Yeah, every ETV paper should have a table of complications. So.
Yeah, so thanks for your presentation. I really would like to know, do you have the feeling that, and also to the other audience members, I would like to know, do you have the feeling that you can stop a basilar artery bleeding with 15 minutes of irrigation? I'm not totally convinced, because in many cases that I have seen, it happens after you deflate the balloon and you have quite a substantial hole in this artery. And I cannot imagine that it ever stops if you just irrigate. So
I think the post-op scan of that particular patient, although it's not mine, but I've seen that scan, has blood everywhere, but there was an EVD placed, and then with time this patient improved. Initially had no response, but later on improved, and is reasonable now, functionally. Having said that, spoken to 2 other guys who have done the same, and both of them felt that after 15 minutes the bleeding was really low, they could put an EVD and come out.
After a while, any bleeding will stop.
Well, like an SEH. Yeah.
In our case, it was a perforator. It was a rupture of the septum. And then it starts to re-bleed on the ICU. If you have a big hole, I think difficult.
Okay. We have another question in the back. Can you go next?
Thank you. You don't use endoscopy for tetraventricular hydrocephalus? Is a question.
How do you mean?
Tetraventricular hydrocephalus.
Yeah.
You don't use endoscopy?
For communicating hydrocephalus, is that what you're saying?
Yes.
Yeah. Communicating, we have used, but, and we have published that as well, but, our results are up to like 50%. So I'm not sure that's the best way to go. So I tell my patients that's the results, so, they don't want to have it anymore.
Because sometimes if you enter in the first ventricle, you can make a communication with lateral cisternal, and it is okay. Sometimes it is tetraventricular, but is not non-communicant hydrocephalus.
Yeah.
Maybe I don't.
Fine, we agree with that, yeah.
Okay.
Okay, great. Thank you very much.
Thank you.
Okay. Our next speaker will be Dr. Schroeder again with hemostasis techniques in intraventricular neuroendoscopy.
Yeah, tetraventricular hydrocephalus is a very good indication. It's an obstructive hydrocephalus. This will work. Can you give me presentation?
We get the slides.
It's about
hemostasis
techniques. You know, when we work in the ventricles, usually it's an underwater surgery. And that's why the problem is there's a small amount of blood we don't see. When you have a microscope and you remove CSF, you would not take care. But under the endoscope with this magnification, it looks like a disaster. So for the treatment of hemorrhage, you need an endoscope with an irrigation channel. Best is inflow, outflow. And then different kinds of hemostasis instruments. We have a bipolar forceps and bipolar diathermy rod. And both can be used for coagulation. See, the bipolar is very effective. When you make coral plexus coagulation, you can take the vessel in between and can coagulate it. And then sometimes we take the bipolar rod. You see, this is a patient, was interesting, with ascites after shunting, and she has a hypertrophic choroid plexus in the temporal horns on both sides. And we took the lotoscope because we are more effective. When you take the flexible scope, the bipolar is much less effective. And even with this, with the big lotter, we took 1.5 hours to coagulate the choroid plexus on each side. But finally, the ascites resolved in this patient. And then for irrigation, we have a big syringe, which is connected to the irrigation channel. Where's my mouse? Can you bring the mouse back? This is your mouse, not mine. Where is this? It's not there. And then we have here the suction tube, which we use sometimes, 2.7 millimeters. So we have different. Why is this not working? The mouse does not want to work. So we have different hemostasis technique. If we have a minor hemorrhage, we just start with irrigation. And we don't take saline for intraventricular surgeries. We take lactate, Ringer solution. You see this is a metastasis at the wall of the ventricle, and we take a biopsy. Does not want to work. And then you see there's some hemorrhage coming, and what we do is just we irrigate. It's not working?
It must have worked there because you right-clicked.
No, this is also not working. Now it's blocked since you moved something.
You just got to get that menu off the screen and then the other one will start working.
Is the mouse working? No. Can you forward one slide? Just go one forward. Yes.
Just click anywhere on there. Now you should work.
So when we have intermediate hemorrhage, we use a small chamber irrigation technique. This was a term was coined by Jonathan McMorring. It was a fellow from US. And he saw the technique and said, yes, this is small chamber irrigation technique. What does it mean? So when we have a hemorrhage, we start with irrigation. Then we go slowly with the endoscope close to the bleeding point. And when we have localizes, we go with the endoscope into the sheath and create a small chamber. You see, and this small chamber can easily be cleared, the view. When there's some bloody CSF, you irrigate and it becomes clear and you can see very well. So one example, was a cyst, a parasagitous cyst. I open it and here you see I cut with the scissors a small artery and immediately it starts to become red. Now, when you do it microsurgically, you don't care. It's just a small vessel. But under the endoscope with the magnification, it looks like a disaster because everything is red. Can you give me the mouse back? And then it starts to bleed, and I irrigate. And you see, I have a glimpse of anatomy with forced irrigation. You see, there's a vessel, and there's some blood coming from. So I go very close, and then I take my... Thank you. Yeah, and then I take my forceps. No, it's not working. The mouse does not work. And then I have some good visualization, and I just took the bipolar to close the vessel. I did not coagulate because I did not see where is it. And you see, it's not the big vessel, it's just the small one. You see, this is a small vessel, very small. So I have identified it. And then I take the bipolar to coagulate this vessel, and I can clear the view. So I don't want to coagulate the big vessel, although it's also not very large, because you can compare to the bipolar rod, which has a diameter of about 2.5. And this small vessel was a problem, and then I coagulated and we could continue. Another case, this is a colloid cyst. You see, by manual technique, I have to pull with a forceps via the side channel, and the main channel there is a bipolar diathermy rod, and I coagulate this vessel several times because it's a small artery. So you get only access to it when you use the bimanual technique to bring the cyst into the space. And then I cut too far proximally, not where I coagulated, and then again it starts to bleed. The same problem occurs, becomes red, you don't see. So we initiate irrigation to have a better view. And then I use my endoscopic sheath as a retractor. So I go into the foramen because I know it's fitting inside. And then you see I go up, and this small chamber can be cleared. So I have to elevate the fornix a little bit because the vessel comes from the telachoidea at the roof of a third ventricle. You see, I have to go up. And you see the small space I create in this sheath. It's clear. I have a good view. And then with the bipolar diathermy rod, I can coagulate this vessel, and I can continue with the surgery. When we have a major hemorrhage, what we use is a dry field technique. Dry field technique means we just remove the CSF completely, so we have a good view. That first we described in 2002 with a resection of colloid cysts, and Joachim Oertel from Hamburg put some cases together where we use this technique. And here, this was a miscommunication between me and my resident, so he should turn, but he pulled already, and you see, boff, the Japanese flag is coming, and this is severe hemorrhage. And again, when you see it under the microscope, you would not take care, but here it looked like a disaster, and it was pretty clear that I cannot clear this view with irrigation. So I take my suction tube, go in, and carefully aspirate the CSF. You have to be very careful that you do not put it on the fornix and aspirate, because then you will damage it. And in all cases where it happens in our colloid cyst series, all these hemorrhages stopped without identification of the bleeding source. So just because of removing of the CSF, it stopped, and I had a good view and can continue with the surgery. You see, the fornix is intact. So this mouse does not work. This is an example of an interventricular tumor. You see, well, vascularized, so I thought it might be a good indication for endoscopic surgery. Then when we look in, you see there are some blood vessels. On the left side is the head of the choroid nucleus, and on the right side you see attachment to the septum. But here it seems to be an origin of the tumor, and on the other side there's a septum. You see there is the problem. So I coagulate small vessels, and then I start to take a biopsy, and all biopsy bite resulted in hemorrhage. So I could not see very well. Coagulate, another bite, it starts again to bleed. So it was a disaster. So then I tried to do the dry field technique. So I removed the CSF, and then I simply, with the suction tube, because the tumor was soft, I removed some of the tumor, but then I realized that this is an ineffective surgery, so it will take too long, and saying it was not a good idea. So I removed my endoscope, and then I take this Viger side view tube system, follow just the track of the endoscope, and then I'm in the third ventricle, and you see now I can use effective suction, and I can remove all the tumor on a direct visualization. So when you have a problem during the surgery and you think with an endoscope you are inefficient or it's risky, or you don't use the endoscope and take these small Viger or any other tube system, diameter is 8 millimeters at the tip, and the endoscope has 6.8. So I think it can be done also with this tube. And you see the tube track is not so large, so for deep-seated lesions the tube is a very nice tool to deal with it. And you can use it under the microscope, but you can also take an endoscope in. So my conclusion is, if I have minor hemorrhage, I just use irrigation, bipolar coagulation, and intermediate hemorrhage, we use small chamber irrigation technique. And if you have a major hemorrhage, you have the dry field technique, but you could also, when you expect you have a high risk of hemorrhage, you just remove it before you start with the surgery, and then you remove it like with a microsurgical technique in an air-filled ventricle. Thank you for your attention.
Questions? I might start with one. Can I ask, when you do the dry field technique, you don't get the collapse of the ventricle, you get shift, and then my second part of the question is, like how much, like how long does it take to, I guess it depends on the size of the child or the adult, like how much CSF do you have to take out?
So when you should place the head straight. When you put it down and you make the dry field technique, the septum comes in your way. That's not good. So you should place the patient straight, that the septum is not coming too much to one side. Of course, when you remove the CSF, sometimes you have collapse of the ventricles. That can occur. It depends on the size, and when you have large ventricles and the septum is thin, of course it comes more than when that is not the case. And the bleeding stopped very, very soon. So I just removed it, and then I looked around, I think 20, 30 seconds, I could not find it.
Nice presentation and very useful. The last video you showed, sir, the dry field technique where you use the scope with the suction on the side. So is that a different scope? Because all along the instruments were going through the scope, it was
yes.
parallel.
Also,
whereas when you shifted to dry field technique, the suction tube was coming outside the zero scope, or was it because coming?
No, it was a working channel. It was not aside.
So the suction is also through the working channel.
Yes.
Only when you converted when the last case went to microscopic, that was with the tube. Rest of all instruments go through the channel itself.
Yes, but in this case I didn't use a tube. I just used my suction, and I have the forceps. I like microsurgical instruments when I use it. But always I take the suction tube through the ventricular scope.
Thank you.
Question right here.
In dry field technique, after you performed your procedures and the follow-up of your patients, did any of them develop extra-axial CSF collection like subdural hygroma?
No, I've never seen it. I fill it, so I don't leave it a long time empty. So when I have my hemostasis, I usually fill it and I start again my procedure for scoleate cyst under water conditions. So I never remove it and then I dissect for 1 hour or so. No, I just remove it to have hemostasis, then I fill it up, also because sometimes the ventricles collapses, and also my bipolar needs some water for coagulation. And that's why it's never a problem. I've never seen that as an extradural collection which has a problem like subdural effusion or so. But what you see when you make a microsurgical operation, it can happen. Yeah, no, I don't see this. And when I use the tube, before I close, I fill it up completely, and then I take fibrin glue to close the corticotomy, to prevent that it's coming out all the time. So I put a lot, let's see, at least 1 centimeter or the whole cortex I fill with fibrin glue. But you have to be careful that's not falling in the ventricle.
Okay, thank you.
Great, thank you. Okay, we have 2 more talks. We'll go back to Dr. Dia Pujari and talk about stock preservation or sacrifice in endoscopic endonasal resection of craniopharyngiomas. And then Dr. Jallo will go last.
So thanks once again. I think when we were reading about craniopharyngiomas, it seems that there are no agreements on most things, and one of the first papers I read on this was a 1983 paper by Raimondi and colleagues who said that if you're trying to do a radical resection, you can safely take away the stalk, and you can actually get reformation of the portal system, and many of the patients would not develop this. Now that we've started doing endonasal transsphenoidal surgery, we think that we can see the stalk better, and we can probably save it better. And initially when we start, most of us would start with a cystic cellular infradiaphragmatic tumor. And even here, depending on how much pituitary is already compromised, patient may or may not have diabetes insipidus. So this patient did not have diabetes insipidus. We went ahead and removed this tumor by removing the tuberculum, extending this into the anterior cranial fossa a little bit. The stalk is coming out. You would find that you can preserve the normal pituitary at the back. And the cyst wall is coming out. And when the cyst wall is coming out, you have to use some dissection because you see a depression of the pituitary stalk at the top and the splayed out gland over here. And this patient, though they require steroids, supplementary steroids, at the end of about 3 months had no diabetes insipidus at all, which makes the quality of life much easier and no obesity. This is the scan after about a year, which showed clear. And I think we became wiser by this classification, which Kasam and colleagues have done about pre-infundibular, transinfundibular, and retroinfundibular variety, intraventricular being the 4th variety, where it is completely above the floor of the 3rd ventricle. So this is one such patient, a recurrent pituitary tumor, recurrent craniopharyngioma, which was operated transcranially first, mainly coming with large cystic recurrence and some solid areas as well. No diabetes insipidus at this time. On preoperative scan, you try to see where the stalk is. Sometimes you can see, sometimes you may not be able to see it so well. And though otherwise it is suitable for endoscopic transsphenoidal surgery, we went ahead and did this. I think for the sake of time, I would probably quickly go through this. The cyst is coming out nicely, and then we are trying to separate it from the stalk, and you would see that this is in the interpeduncular fossa, but I would just like to show you that even in this patient, we have been able to preserve the stalk quite well. Over here, you can see the 3rd ventricle quite well, and you can see the interpeduncular fossa with the cyst quite well. So it is possible to preserve this in this patient, and there has been no diabetes insipidus in this patient except for the 3 to 7 days period when most people have some diuresis. And this is a 1-year post-op scan. This is another patient where the tumor is going slightly onto one side. This is another recurrent tumor. And here again, we use the similar kind of approach. And if you can see that at the end of removal of tumor, you have been able to preserve the stalk, and you're removing the capsule on one side, which is going into the paracellular area here, and it was possible even to get that out because of the broad isthmus. You can see into the Sylvian fissure here, and you have the patient's stalk intact as well. So you make an attempt, but it is not always possible. And I think the biggest problem comes, cannot visualize the stalk at all. So in many patients who have cysts like this, we first drain the cyst by intraventricular endoscopy. And then we would go ahead if the skull base, this is just putting in a reservoir, draining the cyst. And 3 days later, if the anatomy is favorable, we would go for an endoscopic transsphenoidal approach like we are going here. And it becomes much easier once the cyst has been decompressed earlier to remove, to sort of shell it out from the hypothalamus as well as the pituitary stalk, making it easier to save it. And our rate of diabetes insipidus in patients who have been operated by this particular method, 26 cases so far, has been, we published first 20 cases where new onset diabetes insipidus or persistent after 1 year requiring DDAVP was less than 1/3 of the patients. This is a infundibular kind of a case, and here you will find that it is much more difficult. You need to sharply dissect this, but this is a 11-year-old girl, and we went in favor of leaving a little bit of capsule on the stalk. So this is a judgment you have to take, and I think in children, and especially in growing children, and this girl is growing quite well. There was a small recurrence after 5 years of follow-up, and she's recently received radiation after she completed 16 years. This is the kind of patient where it is very difficult. You can see the stalk is going ahead, and we had to go from the dorsum sellae in this patient, and you can go ahead of the, go behind the pituitary and remove these tumors, but invariably you get diabetes insipidus, which persisted for almost a year in this patient, but 5.5 years later, she is tumor-free, and then again a small recurrence was seen at the end of 7 years, and she has received radiation, has remained well after that. This is a recent patient where we could not be sure where the stalk was, and we tried to do a endonasal surgery. You can see that the stalk is splayed all along the anterior aspect, and you can see a glimpse of the tumor here and a very narrow corridor, and you can see the hypophyseal and other arteries over here. So we decided to decompress the cyst like we have done in this patient, and then we have not treated this, and the patient is waiting to see if we should do a transcranial surgery or we should go for radiation. As her vision has improved considerably, she would probably go for fractionated radiation. This is another young female where she's a doctor herself, and she did not want an endocrine deficit, and requested you can decide which way you would prefer to go. And I think with my recent experience where there is a, you can see that there is a, you can see this is the pituitary, the stalk is here, and the tumor is completely behind the infundibulum. And here I decided to go transcranial, pterional approach, and we managed to remove this tumor through the opticocarotid corridor. You can see the stalk splayed in front, which was gradually separated after decompressing the cystic component. And then we have been able to separate the tumor from surroundings after decompression and managed to keep the stalk intact. She is about, these are the scans after 4 months where you can see that the stalk is preserved, and she is on a very small dose of steroids. So I think while the decision to preserve the stalk reduces the rate, most people feel that in a growing patient you should preserve the stalk. Goto has recently written an article in Neurosurgical Focus where he has again emphasized the same thing, and we would certainly avoid to do endonasal surgery in intraventricular, and nowadays I prefer not to do it even in the retroinfundibular tumors. Thank you.
Any questions? Dr. Schroeder?
Chandra, thanks for the nice presentation. Do you have any case where you cut the stalk and the patient has no DI?
I have not had any such patient. To tell you frankly, deliberately I have not cut stalk in any patient. I was operating on a colleague's patients, which was third recurrence, and there we decided to cut it. That's the only patient. She was miserable for first 6 months, but I must say that at 6 years, she had 3 surgeries in first 3 years, and now 6 years she is tumor-free. So they are happy, but she's on DDAVP and several other hormonal supplements. I have not purposely, mostly because most of my patients are young patients.
Do you ever not operate like the medical student who didn't have any hormonal problems? Like, would you ever just watch that? It was a fairly small tumor.
You mean a small remnant?
No, I think it was a medical student. You showed the case.
Yes.
Like, it was fairly small. You said she had no hormonal problems.
She had no hormonal issues, but she had this tumor. She had persistent headaches, and she waited for almost 3 months before she consulted us. She had already consulted other neurosurgeons earlier, and it was only after an observation of about 4 months they decided to come for surgery.
Okay, but will you sometimes have just observed small cranials?
I have done that in an infant. The youngest patient I have treated is 11 months old, where I decided to wait, and at about 14 months we just put a reservoir and interferon, and eventually I operated on the child after the age of 3 years.
Thank you.
Sir, just from your experience, dissecting the capsule from the stalk, optic apparatus, and vessels, ACA and ICA. So how will you rate them, like which is easier, which is difficult?
I think unless it is frankly calcified tumor, dissecting from vessels is not such a big issue, because first-time craniopharyngioma usually does not go beyond the arachnoid. I think if it is repeat surgery or the patient has been previously radiated, we need to worry about that. Unless you make a gross mistake, pull at the tumor with a large calcified portion, you should not damage the vessels. In terms of pituitary stalk, I think most of the problems are because of non-visualization of stalk in large tumors, that we may or may not be able to save it. But if you see it, and if the patient is in a growing age, I would say that I would remove a little bit of capsule if I have any difficulty in separating it. Hypothalamus becomes the most difficult portion, and I think for clear visualization, endonasal approach is much better and has probably, that damage has reduced. Unless the patient has pre-existing hypothalamic dysfunction, one should be able to do a reasonable job and preserve that. To tell you frankly, in pituitary series, we have some visual deterioration. In craniopharyngioma, only one of my patients has deteriorated out of some 180 cases.
Okay, thank you. Do you cut almost the intercavernous sinus for this approach? The coronary sinus?
The intercavernous sinus has
Yes.
to be coagulated. I didn't show that video fully.
Almost.
But yes, we divide that in the middle. There is also another point which Ari first asked the question. Some of the visual damage we get in craniopharyngioma surgery is also probably because of damage to the vessels supplying the optic apparatus rather than separating it from the optic apparatus.
Okay, thank you.
Okay, fabulous. Okay, thank you.